talk is more about why I eventually shifted from conventional to robotic assistance instead of how, because how I shifted is by buying the robo. There were 5 important points which prompted me to change, because I was a regular Oxford user. I still am for the non-robotic UKAs, but 5 things to dwell upon. 1, I used to struggle with draping and always wonder about what's to be done with the other leg. Also, I have had these incidents where the most important instrument, the curly-whirly, would once fell down because I couldn't drape the patient right or hold the instruments right or transfer the instruments. And obviously there will always be a situation where you would want to convert from a partial to a total knee at some time. And then if you're in a leg hanging position with a leg holder, then you either carry on the TKA in that position, or then it's a big mess to re-drape and put the patient back into supine position. Second, you always keep wondering about the difference between fixed and mobile bearings. And I'm robotics assistance company agnostic here, but the idea is that both fixed and mobile bearings have the same outcomes, similar revision rates, and almost the same survivorship. The major difference is, in terms of evidence, is 1, mobile bearings can dislocate, and a fixed bearing has a lot of loading at one point, so polywear is more common, and aseptic loosening is a potential issue. Now, polywear or aseptic loosening is mostly due to component malalignment. If you're undercorrecting the deformity, if you're giving too much slope on the tibia, or if you have an ACL deficiency. Out of these first 3, you would like to do them better, if possible, with technology. Of course, ACL deficiency is more about patient selection. Whereas if you're using the mobile bearings, again, component malposition or unbalanced gaps, insert impingement, all of these you can change. Technology can help you and place the components better and avoid. Of course, if you injure the MCL or if you take a very low tibial cut, you put in a smaller bearing size and you can have instability. That's something that technology can't help you with. But there's definitely evidence that bearing dislocations are significantly higher in the Asian than in the Western population. So if you want to use a fixed bearing, because you don't want bearings to dislocate, and you want to reduce the complications of the fixed bearing in the long term, then you take technology and solve the first 3 issues if you can. Third point, I used to always wonder what happens to that hole when you use the intramedullary guide to cut the femur. In a TKA, we're replacing the entire femur, so that hole also gets replaced. Whereas in a UKA, that just stays there. I don't know what happens to that, but it's not a nice feeling to just leave that hole there. Second, of course, Rohit alluded to this fact that you may not be able to use the conventional spoons and sizing guides for Indian patients all the time. Eventually, it's more about trying to match what you have on table with what the patient has. So femoral sizing is also a problem. The fourth important, and I think this is the most important point that I have seen in my practice. So I see around 40% of patients having constitutional varus at the tibia. So if you are offering a uni, even can extend indications where you have more than 10 degrees of varus, and you want to perform a uni. So if you have a patient with constitutional varus, the ideal way to put in the tibial component is to put it parallel to the joint line. If you use your Oxford jig and you don't move the distal part of the jig a little medially, you are going to cut perpendicular to the mechanical axis of the tibia, in which case you are probably going to end up with an X-ray that's looking over there on the one in the center, where the tibia is actually cut perpendicular to the mechanical axis, but the component is actually placed at a neutral or slightly in valgus, and that's a great stress riser on the tibia. In fact, now there's a lot of talk about trying to go into what kinematically aligned UKAs are. So you want to cut and place the tibial component in a little bit of varus, parallel to the joint line, and all these movements and motions are only possible if you have technology. When you're using the Recipro for an Oxford, the first teaching in all these courses is don't incline your hand a little too much, because you don't want to cut the posterior cortex. If you cut too much, then you're going to increase the stress risers again, and it can lead to unexplained pain, it can lead to a higher incidence of a stress fracture, and so many other issues. Also, the deeper you cut the tibia, again, there's softer cancellous bone, more chances of subsidence, more issues. All of this related to how you're cutting the tibia. But if you have technology helping you to cut the tibia at the same level, case after case, I think you can reduce this issue. Lastly, the most important point they say that can be solved with robotics assistance is joint line obliquity, or the joint line orientation. So there is a chance that you may distalize the femur, especially if you offer an Oxford or a UKA in a patient with diffuse cartilage wear, but not a completely worn out condyle. So you may sort of supersize the femur. If the femoral component, like on the right-hand side X-ray, moves a little distal, then the joint line is not restored, and that can lead to an unhappy patient. So to summarize, if you want to shift to robotics and reduce your proportion of Oxfords and increase your proportion of robotics, then the reasons could be, should be, surgeries can be done in supine position, UKA or TKA. A well-placed fixed bearing prosthesis with no bearing issues can be used. You can place the components better. You can restore the joint line better. Thank you.